Hello, everybody. Welcome to the ATS COVID-19 Critical Care Training Forum. We're going to give everybody just a couple more minutes to log on, so make yourselves at home. And in the chat box, feel free to tell us where you're from. Right. Virginia, India, Oklahoma, Manila. Fantastic. We love to see the international contingent on these forums. It's always a pleasure. So for you, those of you who just joined us, we're just going to get started in a couple more minutes. We've got Saudi Arabia in the house, and Canada, and Mexico, and Venezuela, Peru. Fantastic. All right, let's go ahead and get started. Hello, everybody. I'm Dr. Laura Crotty Alexander. I'm an associate professor of medicine at UC San Diego. And it is my pleasure to moderate this session of the American Thoracic Society COVID-19 Critical Care Training Forum. So we run these forums, or will be running these forums, every Tuesday evening at 8 to 9 p.m. Eastern Standard Time. And we do want feedback on these forums, so we're going to run these for the next couple of months, and we can design the forums around your needs and desires. So we'll be posting this link in the chat box so that you can fill out the survey about tonight's forum. You can also use that QR code on your phone's camera to go ahead and get that survey all booted up and ready. So we already taped and posted 13 of these forums. You can find them if you just search for ATS COVID Forum. And we'll also be pasting that link to the 13 prior episodes in the chat box so you can check those out. They covered all kinds of topics such as the coagulation state in COVID, post-hospital care, ventilator management of COVID. So lots of good pearls in there for you to check out. And of course, we wouldn't have this awesome forum without our chairs. So I'm one of the co-chairs, but Dr. Viren Kaul, Nirav Shah, and Sushma Cribbs have done a lot of work here. And Dr. Cribbs only has 2 B's in her name, so apologies for that. And we have a wonderful team of trainees, some of whom are on the call tonight that really get this going. Finally, the ATS staffers, Lauren Lynch, Liz Guzman, Eileen Larson, and Rebecca Fish do a lot of work to put these on, and we really appreciate that. So today, let me backtrack a second. We're going to start off with Dr. Erica Lin from UCSD. She's one of our stellar pulmonary critical care fellows. She's going to walk us through one of the severe hypoxemic COVID cases that we've had. And then Dr. Bellinghausen is going to take over and take us through best practices in caring for a hypoxemic, critically ill COVID-19 patient. Dr. Cameron McGuire, another one of our fellows, is going to do his special session on updates and controversies in COVID care. And we're going to round out the session with a really fun discussion about what the potential and likely mechanisms are underlying the hypoxemia in COVID. So with that, I'm going to pass the baton to Erica. I would like everybody to, if you can turn off, nobody ever rings our doorbell, so that's a surprise. But if everybody can turn off your video so that we can stream the screen for Erica, that would be great. And if you have any questions along the way, please do enter them into the chat box. We have multiple experts on the line who would love to answer your questions. So Erica, I'm going to go ahead and pull up your slide deck.
Perfect. Can you hear me?
Yes.
Okay. So again, thank you so much for the introduction. As Dr. Laura Crotty mentioned, I'm a third-year PCCM fellow at UCSD. And again, by now you've all sort of managed COVID patients. I'm just going to be presenting one of our classic COVID patients that really highlights some of the best practice management of COVID ARDS. And hopefully this will set the stage prior to hearing from our expert discussant, Dr. Amy Bellinghausen. So we have a 48-year-old with a history of high blood pressure and diabetes that's pretty well controlled. And he reported 1 week of subjective fevers, chills, and respiratory symptoms in the setting of a COVID exposure. He received azithromycin and hydroxychloroquine, but had worsening respiratory symptoms and overall presented to the outside hospital ED, quite hypoxemic. He actually initially required 6 liters of oxygen. And at the outside hospital, he received targeted COVID therapies, including most recently remdesivir and dexamethasone that Dr. Bellinghausen will talk about, as well as convalescent plasma. But gosh, despite all of these therapies, he continued to worsen, and he ultimately intermittently required BiPAP. He initially was quite adamant about holding off on intubation at the outside hospital, and ultimately was transferred to UCSD for further management. And these are his vital signs when he first came to our ICU. Initially, he was quite hypoxemic on a non-rebreather with SpO2s in the low 90s. However, he did appear very well appearing, and he didn't have any significant work of breathing. So he sort of fell into that category of patients that we've seen with silent hypoxemia. And you can see some of his basic laboratory studies and images as shown. I just want to note his emission chest X-ray that you can see his diffuse opacities as well as his initial ABG with a PO2 of 51 on a non-rebreather. So I'm sort of going to pull the room here, and I think Dr. Crotty, you may have to tell me what people are choosing here, but in the circumstances in a patient who has these radiographic findings, what would you continue to do? And I do want to mention that while he was on a non-rebreather, intermittently he would desaturate down. He would have to take a couple of breaths in order to maintain his stats. So would you A, continue to monitor it, change him to high flow, resume BiPAP at the outside hospital, or just proceed with intubation?
Awesome. So we already have 1 vote in the chat box, so go ahead and type in your votes if you have strong feelings. We got a lot of votes for B thus far, not to bias people who are typing it in. Got some high flow level lovers on the line. We got a C, we got a D. More D's and B's,
overnight,
so a lot of people are saying, yeah, that he needs something more.
Oh, gotcha. Well, overnight he actually became quite hypoxemic and was unable to maintain his stats. He had worsening encephalopathy and was ultimately intubated within 24 hours of coming to our hospital. Initially, his post-intubation ABG showed a PF ratio of 82, suggesting a pretty severe ARDS pattern. And he was managed with good ARDS care. So he was provided with a low tidal volume ventilation. And because of his degree of ARDS, as well as his significant ventilator desynchronate, he was paralyzed and prone. And for what it's worth, his PF ratio, while prone, did increase from 80s to the 100s. Again, it wasn't sustained, and it would turn back down to the 80s when he was supinated. And during those next 48 to 72 hours, he was aggressively diuresed in order to maintain a negative or relatively conservative fluid balance. After about 48 to 72 hours, his ABG continued to show a PF ratio of around 93, despite high PEEP and low tidal volume ventilation and these aggressive paralysis and proning measures. Additionally, his radiologic findings were also suggestive of a slight worsening from admission, and given his young age, his relatively well-controlled comorbidities, and his single organ failure, he was considered a really good ECMO candidate, and he was ultimately cannulated for VV ECMO. So I want to show you again his progression through his hospitalization, and I want to do that with his images. And you can see that, again, we monitor his x-rays quite sparingly, but you can see his chest x-ray progression that shows really worsening opacities bilaterally up to most recently about week 4, prior to having some improvement. Additionally, you can follow along these images to show some of his hospitalization course. So initially he had an ET tube. You can see that he has a cannula for VV ECMO including in his right IJ, and ultimately got a tracheostomy. And most recently, he started to have some improvement closer to week 4 and 5. And I just also wanted to poll the audience to see when you guys would consider tracheostomy. And again, Dr. Laura Crotty, I think you may have to man the chat room and let me know what people say.
Yeah, so what do people tend to do or think is appropriate for tracheostomy? A is 1 week into mechanical ventilation, B is 2 weeks in, C is 3 weeks in, D is a time of placement on ECMO, and E is never. So we have a lot of votes for B. We have an A, we have some Ds. I think the vast majority is B.
Sure. So at our facility, again, it's been changing. We do know that there are some facilities that do tend to do early tracheostomy. Since we had the time, we did wait and see for negative COVID to decrease exposure, as well as slightly improve ventilator requirements just to ensure that it can be performed under apnea with the least amount of exposure to our wonderful interventional pulmonology procedural team.
How long did he stay positive, Erica?
He did not stay, by the time he came to us, it was actually close to 3 weeks past his initial exposure, and he was still positive at that time.
Great.
For the sake of our presentation, I am going to sort of speed through some of the complications in his hospitalization to provide some time for our expert discussant. I do want to discuss some of the things that we have seen. He developed ventilator-associated pneumonia, which we have seen quite frequently in our ECMO patients. He had a spontaneous retroperitoneal bleed while he was on anticoagulation for VV ECMO. He had ICU-related delirium as well as oxygenator with his ECMO circuit, and that did have to be replaced. He had bleeding from his tracheostomy that ultimately required cryotherapy by our IP service, as well as significant peripheral eosinophilia of unclear etiology, but presumably most likely secondary to some sort of drug-related reaction. And as mentioned before, he is starting to show objective signs of improvement, and we are doing sweep challenges over the weekend, and we're hopeful that he can be decannulated early this week. The great thing is that he has been able to mobilize with physical therapy and occupational therapy while on ECMO, which has been helped with the use of a tracheostomy and decreased sedations. Now, I did want to show a timeline of his prolonged course. You can see that he had symptoms starting on day 1, was intubated on day 20 or so, placed on ECMO shortly after to really promote this early ECMO that we've seen, which has been a little bit more beneficial, underwent tracheostomy and is recovering by day 70. So he has had quite a prolonged course. And there could be an argument that this may be related to COVID, but may also be a component of patient self-inflicted lung injury while he was on BiPAP. And the last thing I'd like to mention before handing the microphone over to Dr. Amy Bellinghausen is that really the management of COVID patients just focuses on good ICU management and above all good ARDS management. So I've highlighted some of the things that are important from ARDS management that you all know of, including the low tidal volume ventilation, proning, conservative fluid balance, plus or minus process, and ECMO. So with that, I think I'll hand the microphone back to Dr. Laura Crotty Alexander so she can introduce our expert discussant, who will sort of delve into the best practice management of COVID-19.
Thank you so much for presenting that case, Dr. Lin. That's a fascinating case. I really hope he does well and gets off the ECMO. We did ask a question in the chat box about whether at your local institutions, do you wait for a negative COVID test prior to a tracheostomy? This was actually a big discussion when we were holding forums a couple months ago, where people were very resistant to tracheing our ARDS COVID patients. And some institutions were waiting for a negative test, and so we're swabbing their patients, every few days. But it looks like from the chat box that most institutions that are voting, at least, are saying that they aren't waiting for a no, but they're doing full PPE during the trach procedure. With that, it's my pleasure to welcome back Dr. Amy Bellinghausen Stewart to our forum. She is one of our fourth-year fellows, but knows more than most of us attending. So I was really excited that she wanted to speak to us tonight about the best practices in taking care of COVID-19 patients in the ICU. So Dr. Bellinghausen, take it away.
Well, thank you. And thank you guys for inviting me. Happy to be talking a little bit about this. I think Erica Lynn set up a great case to discuss some of the best ICU practices for COVID-19. I think a lot of what you're going to hear from me and what you're going to hear from everyone today is good COVID care is good ARDS care is good ICU care. So good ARDS care, low tidal volume ventilation. Unfortunately, we have no COVID specific data for this, but we do know that low tidal volume ventilation, 6 to 8 cc's per kilo ideal body weight, seems to be beneficial in ARDS. That's not news to anyone, I'm sure, but we think that also it's beneficial in COVID-19. What we don't know yet is whether even lower tidal volume ventilation might potentially have more benefit. Prone positioning. I think this has been one of the bigger things that's come out with COVID. The somewhat unfortunately named Prawn COVID study has come out and is in progress with a preliminary report looking at growing evidence for non-intubated patients with COVID-19 related hypoxemia. The idea being that potentially proning these patients before they get intubated can help prevent lung injury, worsening lung injury. Certainly any patient that you have who has ARDS with a P to F ratio less than 150 should be proned. Manual proning is more practical in general than using a bed just because it takes less time. Also, with prone positioning, that doesn't necessarily have to stop once someone goes on ECMO. It gets a little bit more complicated, but it is something that we have done. Paralytics, as needed to prevent dysynchrony and facilitate low tidal volume ventilation. Of course, again, there's no systematic COVID-19 specific data. Anecdotally, I've been using paralytics pretty frequently just because there is so much asynchrony early in COVID-19. Good ICU care, ABCDEF bundle or fast hugs, whatever your institution uses to go through the checklist of life-saving ICU strategies. Whenever I'm working with house staff, I tell them that these are not the fun sort of sexy things that brought us into ICU care, but they are the things that save lives. So sedation, choice of sedation is one. I'm really worried. My other hat is the post-ICU person at UCSD. I'm really worried about the increased benzodiazepine use that I've been seeing because these patients have been difficult to sedate and keep synchronous on the ventilator. Seeing a lot more benzos. I think being judicious about that is still really important. It's one of the drips that we know increases mortality risk. Anticoagulation has been an ongoing debate in COVID. Prophylactic anticoagulation, definitely benefit. Therapeutic, more questionable. There have been some suggestions that therapeutic anticoagulation might be indicated for COVID-19. I think that case has not yet been made well in the literature, and our practice has not been to start therapeutic anticoagulation empirically for COVID patients. Treating bacterial infections, and this is something, again, that I think has evolved over the course of the pandemic, is our understanding of how frequent bacterial co-infection is. Estimates for the rate can range from 8% to 50%. Our practice has been to give broad spectrum antibiotics for usually 24 to 48 hours and then de-escalate based on cultures. NSAIDs, again, initially some concern that those were harmful in COVID-19. An observational study seems to have shown that there's no increased risk, although of course, with every ICU patient, there's a risk of NSAIDs with AKI, bleeding, etc. All right, so the therapeutics. In COVID-19, we have been seeing multiple new trials coming out very quickly. This is just a table summarizing some of the agents that we're using. Probably the two that have the best data are the ones in bold, remdesivir and dexamethasone. Remdesivir was what was studied in the Act 1 trial. UCSD was part of that. Unfortunately, and this is just a graph showing in patients on mechanical ventilation or ECMO, there was really very little separation in the curves between placebo and remdesivir in terms of mortality. So although remdesivir did show benefit in COVID, it did not show much of a benefit in our sickest patients or the patients we're seeing in the ICU. Our practice still has been to give it, hoping that, potentially there just wasn't a big enough sample size to see a clear difference in these groups, but unfortunately data is not great. What did come out next is the dexamethasone arm of the recovery trial. That did show benefit in patients on mechanical ventilation. So this is the graph of patients in the recovery trial on mechanical ventilation. It did show separation between usual care and Decadron with a reduction in mortality. So we have been using that. Plaquenil does not have good evidence, seems to cause more harm, if anything. Convalescent plasma has not had an RCT that showed benefit. The one that we did have was actually stopped early due to lack of benefit. And then baricitinib, the JAK inhibitor, is in progress with Act 2, and that's baricitinib plus remdesivir or remdesivir alone. And TOSI, unfortunately, did not show benefit in a report of Covacta. All right. Lots of other agents have been proposed, everything from vitamin C. My MA in clinic today asked me if lemon tea cured COVID. Unfortunately, no luck there. Did I hear a vote for lemon tea?
Yes, I would totally take lemon tea over some of the other options.
Sounds like a plan to me. His family was quite convinced. All right, so some other considerations: non-invasive positive pressure ventilation or high flow nasal cannula. That's something that came up in Dr. Lynn's case. Is what is the role of non-invasive positive pressure ventilation or high flow nasal cannula in COVID? I was reading through one review on COVID-19 and strategies to deliver oxygen to delay intubation. Unfortunately, the review stated in its first line that there were no studies included of COVID-19, which was somewhat less than helpful. So really the data that we do have is observational data, which is of low quality. The surviving sepsis folks with Society for Critical Care and European Society for ICU Care have recommended a weak preference for high flow nasal cannula over non-invasive positive pressure ventilation. That's based in part on previous trials showing reduced intubation in ARDS, and the data from SARS showing increased risk of transmission to healthcare workers with non-invasive positive pressure ventilation. Unfortunately, at this point, I think we just don't know enough to say one way or the other which is better. We have been using some high flow nasal cannula in COVID patients. At UCSD, we are actually using a veil device, which is sort of a clear plastic cover, but data is still early. So ECMO, again, widely used as a rescue therapy for COVID-19 ARDS. Be prepared for a long course. The folks in Chicago had a observational study of 40 patients who underwent ECMO for COVID-19. And this is their graph of events. And you can see, so this was as they're recruiting up to the 40th ECMO patient. And 6 of the patients died, but you can see how long it took patients to get to extubation, decannulation, and discharge from the ICU. The mean ECMO duration was actually 29.9 days, which is a lot. Inhaled nitric oxide or inhaled Flolan epoprostenol seems to improve oxygenation in ARDS, but no proven mortality benefit. There is a randomized control trial in progress for COVID-19 associated ARDS. I have no insider information about when that's coming out, but hopefully soon. I certainly have used a lot of nitric oxide. I think the only danger there is if you are using it to improve oxygenation, don't delay proning, which has a mortality benefit. So protecting staff, thoughtful use of aerosol generating procedures and diagnostics. I think it's always good in the ICU, but COVID particularly has reminded me to ask myself, do I need that CT scan? Do I need that chest x-ray? How can we facilitate bundled care from the nurses? And do we need that bronchoscopy? We do perform those procedures with proper PPE for staff, including N95 for any intubated patient or aerosol generating procedure. But again, only in cases where we feel that the risk is truly outweighed by the benefits. So lastly, I just wanted to mention a word about psychosocial concerns. There's a lot of staff burnout with COVID-19, and I think it's important to keep this in mind as a part of our COVID ICU care. We know that burnt out doctors, nurses, respiratory therapists provide poorer care and have poorer outcomes for themselves. I think it's crucial as the leaders of the critical care team to encourage regular breaks for all of our staff, including physicians, and then utilizing debriefs and team check-ins to make sure that we're communicating about what the plan is for patients and what things look like going forward. Families also are in a whole new world of not being able to be bedside. I know that... I'm sorry? Okay. So families also are, not able to come in and see their loved one. It's extremely difficult for family members to understand what is truly going on with their loved one when they can't be there, can't see what's happening. We've been using video chats for patient families, even when their family members are intubated or on ECMO, so that they can at least have a visual for where their family member is at then. And I think that has helped a lot. Daily check-ins with the physician and nurses are crucial. And one thing that we've done with our ECMO patients that I think has been tremendously helpful is scheduled weekly meetings with the palliative care team, generally including a social worker. That's been something that's really been helpful as kind of a weekly sum up. And lastly, delirium and PICS. Like I said, my other hat is the ICU recovery clinic doc. And these patients who are in the ICU for COVID are in the ICU for tremendous amounts of time. They are developing ICU acquired weakness, ICU neuropathies. They have sometimes orthopedic injuries after proning. And it's important that these patients, whether it's through their PCPs, through their pulmonologists, or an ICU recovery clinic, have screening for symptoms of post-intensive care syndrome. And with that, I can take any questions.
Terrific. Thank you so much, Amy. You really cruised through like the highlights of how to take care of these super sick patients and sort of best practices. So thank you for sharing that. And I know that you have particular interest in the post-ICU care. And what have you seen in your post-ICU COVID patients so far?
Really variable. I have seen some very sweet little grandmothers who I thought were never going to make it out of the hospital, who, 6 weeks after the ICU are back to doing what they love and doing their chores and feel fine and have no complaints. And I've seen 20-some and 30-some-year-olds where they are having nightmares every night, they can't function, they can't stand up from a chair. And it's really goes a whole spectrum. But I think just being alert to some of the things that patients are going to be dealing with even after they recover is important.
Gotcha. You had brought up burnout, so I had put in the chat box, how are people handling burnout at their separate institutions, including taking care of themselves. So if anybody wants to put into the chat box how you're doing that. One person mentioned weekly debriefing with the psychiatry department, plus personal consults as needed. So I was glad to hear that there's some like formal stuff involved. Anything you would recommend, Amy, as you look for burnout, try and help staff with burnout?
Well, at UCSD, we do have the HERE program, which I think is fantastic. It's available for individual providers. It's sort of a counselor for debriefing, and they also do weekly bi-monthly sessions in our ICU, going over some of the difficult cases. Just now talking with some of our internal medicine folks about doing more scheduled debriefs for the house staff. I think just checking in with colleagues, finding ways to get away from work, and taking vacation, whatever that looks like in this day of COVID, but finding ways to get away from it.
Awesome. I see Dr. Dua mentioning socially distanced picnics in Central Park with the team. So that sounds like an awesome idea. And I'm going to let Amy answer Dr. Fernandez's question in the chat box. And anybody else who wants to post comments and questions, please do so, and we will get to them all. I'm going to pass the mic to Dr. Cameron McGuire, who is one of our, again, stellar pulmonary critical care fellows. He's run this special session before for the forum called Updates and Controversies in COVID-19. Since a lot has happened since the last forum, we just want to give everybody the most up-to-date knowledge we can. And so take it away, Cameron.
Great. Thanks, Dr. Crotty Alexander. Thanks, Dr. Bellinghausen. Can everybody hear me okay? And see my screen?
Yeah, okay.
Yes.
Great. All right. So for this week's version of Updates and Controversies in COVID, I'd like to start by reminding everyone about the landscape of the COVID literature. This is the current trend of publications on a week-by-week basis that specifically reference COVID. The week in question that we'll be discussing had over about 2,050 publications. And having done my residency training in Colorado, if you look at the overall cumulative number of publications in COVID, it looks like a very nice blue slope on the mountains. So we'll get right into it. I'm going to talk about a host of different things, some from the actual medical literature and some from not so much the medical literature. So first and foremost, COVID disproportionately affects at-risk populations. I think we have all come to find this to be a truth over the course of our clinical experience with it over the past few months. This is a figure from a letter to the editor of the New England Journal of Medicine from last week, showing the disproportionate effect on Black and Latinx populations of patients here in the US in multiple different states. You'll notice that the case rates and death rates are significantly higher relative to the population rate in almost every single one of these states. If you look at California specifically where we practice, you'll notice that the Latinx community is disproportionately affected. And I can think of multiple incidences in the past few months where we've had two patients with similar sounding last names with equally severe COVID, and sometimes even keeping them straight is challenging because it seems like the entire intensive care unit is filled with patients of Hispanic origin, which is quite unfortunate. Another thing that we've found recently that was just sent as a letter to the editor in JAMA is that the US prison population, and I suspect that this is similar in some of your countries as well, is incredibly disproportionately affected by COVID. So there is 5.5 times the rate of cases in the prison population relative to the general population in the US. And there's 3 times the death rate when you account for 65-year-olds and remove 65 or older and remove them from the analysis, since very few people over the age of 65 are in the US penal system. And then perhaps most importantly, the daily case growth rate has a mean growth rate of 8.3% per day in US prisons relative to about 3.3% per day in the general population. So we know that at-risk populations are disproportionately affected, and we're seeing that in our hospitals. I'm sure you all are in the countries that you're tuning in from as well. All right, so We do know that COVID spread can be slowed, potentially even stopped. New Zealand gave us a great case example in the New England Journal this past week and a half ago now. This is a very busy slide, so don't worry looking at this figure, but these are all of the different behavioral changes that they implemented on a nationwide basis to bring the transmission of COVID down to completely zero cases of community transmission over 100 days. I do note the irony of that, given that they had a recent return of cases at their border just a few days ago. To give you a little more perspective, last week, 8 cases were newly diagnosed in Auckland, seemingly out of nowhere. The entire city, which is about 33% of the entire country's population, was placed on home order lockdown with the exception of essential trips after only 8 cases broke out, which is pretty impressive in my mind. I'd like to contrast that with what happened in Las Vegas in July here in our home country of the US. So this is a map that was actually published just today, so I'm cheating a bit, it wasn't last week, but this is 26,000 cell phones that have health apps and nutrition apps that have live tracking data available. And basically a cell phone company looked at 26,000 phones that were on the Las Vegas Strip in a weekend in the middle of July. And then they followed those 26,000 cell phones over the next 5 days, Monday to Friday, and they looked at how they spread across the United States. And this is the map. So the heat map basically shows the dispersion of those 26,000 cell phones to every single state in the continental US with the exception of Maine. 3,700 of those cell phones ended up in Southern California, presumably either in LA or San Diego, where we're seeing a disproportionate number of cases. So that's quite terrifying. I highly doubt that our country would do anything with 8 new cases diagnosed regarding lockdowns in the way that Auckland and New Zealand have. All right, I seem to be kind of repeating myself. For those of you who've tuned in before, this is my 3rd time doing this, but hydroxychloroquine is still not a miracle drug. There was a publication today in the Annals of Internal Medicine, which I'll let you look at. But I want to just go through this one more time for those who still sort of question its efficacy. And the reason I'm doing this is that we are getting patients transferred to us on a near daily basis from outside hospitals where they are still attempting to use hydroxychloroquine. So there are a few trials where it showed benefit. I don't want to dismiss those trials offhand. These are those 4 major trials. They are all either retrospective or case cohort studies. The Gautret articles from France were the ones published early in the course of this illness that led to a lot of media sensation. And then there were 2 retrospective trials that didn't show any benefit with a much larger N, one done in New York City by Rosenberg et al., and the other one is the VA study. And people sort of said, well, you know, those are retrospective. You can't really compare those. So how about a randomized controlled trial? Well, that was done by 2 separate people, Boulware and then a Spanish group. And the Spanish group ended their trial early. People criticized that trial and said, well, that's pre-exposure prophylaxis. It wasn't done on sick patients in the hospital. And so since then, 5 randomized controlled trials have been done or are ongoing. The recovery trial in the UK, the ORCID trial here in the US by the PEDAL network, which was stopped early due to lack of benefit. The Solidarity trial, which was done by the World Health Organization, also stopped early due to benefit, and the N wasn't given, so it's not factored into my calculations here at the bottom. And then Cavalcanti did one, a randomized control trial in Brazil that was published just a couple weeks ago in the New England Journal of Medicine. So when you take this all in summary, about 3,100 patients were in trials that showed some benefit in a retrospective and or case cohort fashion for hydroxychloroquine. And over 10,700 and counting were in trials with better design that showed no benefit, maybe some harm, but at least no benefit to using hydroxychloroquine. So I think the take-home message is fairly clear. This article that was published today basically comes to the conclusion that the data are insufficient to make any recommendations about hydroxychloroquine or chloroquine for treatment or prophylaxis of COVID-19 for those who don't want to read the article. But it's really impressive, and they look at a bunch of other trials that I didn't include in these tables. Okay, so if I do a 4th one, hopefully we won't be talking about hydroxychloroquine and chloroquine, but it's possible. Moving on, vaccines are coming and quickly. This is actually already outdated. This is from the Washington Post yesterday. The New York Times and Washington Post have these really nice vaccine trackers that I'd recommend people use. It helps you find the actual primary literature as well by getting you links to the sites. But there are actually now 8 phase 3 vaccines and 2 that have been approved as of today. But these vaccines are not coming from Russia, despite the recent media release. So this is the 7 that are currently in phase 3 trials based on when I made this slide yesterday. You'll notice over here, they are all from the UK, China, the US, Germany, or some conglomeration of, say, a German biopharmaceutical research company and then a separate biopharmaceutical research development group, such as like AstraZeneca or Pfizer, et cetera. The Russian thing we should probably just talk about briefly, because even though it wasn't really in the medical literature, it probably dominated headlines more than anything else in the past 10 days. So the Russian vaccine, which has now been named Sputnik 5 by Putin, which is kind of a cute name, has so far been tested in only 76 people prior to their National Ministry of Health filing for a certificate for production, which basically means they will now make this at a larger scale to implement and give to people. The certificate specifies that it can't be widely used until actually January 1st of 2021, but that actually is just around the corner. So they've started a phase 3 trial in Russia, the United Arab Emirates, Saudi Arabia, and a couple of other countries. And the pharmaceutical company that has been contracted to make the vaccines, called Binopharm, which is a Russian pharmaceutical company, currently only has the capacity to produce about 1.5 million vaccines per year, which, if you are doing the math, the population of Manhattan is about 1.6 million. So it doesn't mean that vaccines are coming, you know, post haste, and particularly not from Russia. Okay, so that's the vaccine landscape. They are coming. There are a lot that are going on. There are a lot that are in phase 3 trials with testing going on in multiple countries, but they're not here yet. The next thing is we don't know what we don't know. That's a bit of a tautology, but I want to focus on this a little bit as we, in the US at least, start to open up our country more and more. There was this article published in Science a couple of weeks ago about brain fog and heart damage and other lingering problems from COVID-19 infection well after someone's convalescence. And there have been some specific articles in the medical literature about various organ systems with lingering effects. So there's this one from our colleagues just up the street at USC about long-term pulmonary consequences of coronavirus. And I think someone mentioned in the chat earlier about ongoing dyspnea even after recovery from COVID and testing antibody negative. There's a recent study from the journal called Brain, where our neurologic colleagues looked at 43 patients with pretty severe neurological complications from COVID, including encephalopathies, inflammatory myelitis, ischemic strokes, peripheral neurologic abnormalities, etc. Very few of these patients made full recoveries from their neurological insults. And then there was this study that was published just a couple of weeks ago, looking at 100 patients with cardiac involved or with SARS-CoV-2 positivity, who then had subsequent cardiac magnetic resonance imaging done after their convalescence and testing antibody negative. 78% of them had cardiac involvement by MRI, 60% of them had ongoing myocardial inflammation under cardiac MRI, and very few of them had any pre-existing risk factors for cardiac disease. And then probably most concerning, given how little we know in general about obstetrics and gynecology as internal medicine physicians, was this letter to the editor from the New England Journal just a couple of days ago. An OBGYN group from Washington, DC looked at all of the existing publications, which is 28 papers from Wuhan, China, and identified 401 live births of infants, 10 of whom tested antibody positive for COVID, which is 2.5% for those doing the math. If we extrapolate that out to the number of people who are born per year, I am terrified at what that could potentially mean, since we know so little about how COVID affects the children, let alone neonates. So we don't know what we don't know. And then last but not least is this legacy or perhaps cautionary tale of COVID-19. So quick survey of the group, who knew about this particular website? I thought it was MedRxiv, which I thought was a really weird name, but when I read about it a little more, it's called MedArchive. Who knew about this before the outbreak of COVID in January or February of this year?
Barely. Let's see, White saying not me. Some other people saying nope.
Yep, I sure didn't. So it turns out that this preprint server, MedArchive, debuted June of last year. I'm guessing I missed out on that because I was moving here from Colorado to start my fellowship and was busy doing other things. Or maybe I just would have missed out on it no matter what. But you can see here that they specifically say that it's a preprint server for things that have not yet been peer reviewed. And they caution here that these should not guide clinical practice, nor should they be reported in the news media as established information. And here's another disclaimer within their COVID subset of publications, which shows 7,802 articles on the medRxiv server. Unfortunately, disclaimers, though they disclaim, they rarely dissuade. And almost all of those hydroxychloroquine studies I mentioned just a few slides previously were initially published on this medRxiv server before being published in any peer-reviewed journals. And most of the references from popular media, if you go back and look at archived web pages from February, March, and April and May, reference the medRxiv paper rather than the actual journal article because they had not yet been published. And I think that that's perhaps at the expense of sounding like a Luddite, I think that that is perhaps the cautionary tale of this COVID-19 pandemic, is that with all of the unknowns that are going on, there's always a rush to implement changes, perhaps practice changes, and sometimes the data are unreliable or scant. And I've said this before, but I'll say it again, I would caution people about maybe taking a little bit more time before implementing some of these changes that we have all seen mentioned in the media. So that's all I have this week. Stay tuned for more updates and controversies on a week-to-week basis, but don't worry, it won't always be me. Thanks for listening, and see you guys later.
Thank you, Cameron. That was wonderful as usual. Really covered a ton of ground. And anybody who is desperately trying to take notes, we will post these on the website soon, so look for that. I'm also putting in the chat box right now. If you could please take our survey. What this does is it tells us a little bit about who tunes in. We know that there's a lot of international participants, but we also want to know, are you a physician? Are you a nurse? Are you a respiratory therapist? So that we can try and target you and make sure you're getting the training that you need. And you tell us what you want for the next few forums coming up. So we do have a session coming up in 2 to 3 weeks about OB-GYN, so obstetrics, gynecology in COVID. And following that, we're going to have a post-ICU care session. And then we're going to have a sort of what diseases and symptoms we're seeing in COVID patients after the acute phase. So lots of areas to cover, but you tell us, what else would you like to hear about? So now we're going to move into our final segment for this forum tonight. So the most exciting one that I've been looking forward to. So it's my pleasure to introduce Dr. Atul Malhotra, who is a professor, the Kin Moser Professor of Medicine here at UCSD, and a world-renowned expert on ARDS and sleep medicine, and like all things pulmonary critical care. And he's willing to join us tonight to talk a bit about what are the mechanisms behind the severe hypoxemia we're seeing in COVID-19. And what's coming down the line about answers to that question as well. So thank you for coming, Atul. I'll let you jump in.
No problem. Can you hear me okay?
Yes.
And can you see my pointer?
Yes.
Okay, well, thank you. Great prior presentations, and thank you to the organizers, and thanks to the ATS for having me. I will say I was a former officer of the American Thoracic Society, and I certainly encourage participants of this to join. It's free for residents for your first year, so you should go ahead and do that. There's a lot of upside, as these lectures might help you indicate. So I'm going to talk about mechanisms of hypoxemia. It's sort of a kind of a boring topic in the sense that it's kind of classic physiology, but I'll explain why it's important. I'll start out by saying when you talk about COVID, there are lots of people out there that are saying this is not ARDS, and so I made up a cute acronym, TINA, this is not ARDS. And I think people that are saying that don't appreciate the Berlin definition of ARDS, and I encourage you to review that. There's nothing in there about lung compliance or anything else, and so these patients have ARDS, at least by my estimation. If you look at what the New York hospitals are reporting, it is quite variable in terms of what we see in COVID. Some are reporting a lot of vascular clot, and they're giving heparin and thrombolytics. Some are talking a lot about mucus hypersecretion, and they're doing a lot of bronchoscopy. Some are talking about capillary leak, and it's unclear what to do about that. Some are talking about alveolar flooding with high surface tension, perhaps doing recruitment to increase the PEEP, and recruitment maneuvers may be helpful there. And some are talking about cardiac dysfunction, as Dr. McGuire just mentioned. The bottom line is it's quite variable. And so COVID, people aren't getting gas exchange abnormalities for one reason. But that's similar to typical ARDS, and so people that say this isn't ARDS, I don't agree with. There's certainly abnormalities in gas exchange and control of breathing, as well as in terms of lung mechanics. So what are the causes of hypoxemia in general? And this goes back to John West physiology. John West is a emeritus professor at UCSD who wrote some of the Bibles of respiratory physiology. So what are the causes? There's a low PiO2, that is a partial pressure of inspired oxygen. There's low VQ units, ventilation to perfusion ratio. I'll talk about that more in a second. There's shunt, where there's areas that are perfused without ventilation, extremely low VQ. There's hypoventilation, the CO2 goes up and the O2 goes down. And there's something about low mixed venous oxygen. If the oxygen tensions in the veins are low and there's a lot of shunt, that can end up on the arterial side. You might say, who cares? Why does it matter in terms of what's causing hypoxemia? I won't go through the paper in detail, but Jesus Villar and my former colleague Bob Kazmarek have written about this. It turns out it is prognostic, who has VQ abnormalities versus shunt. It does change management. It is important. And so it's not just an academic exercise. What happens in COVID is not entirely clear. There's certainly patients that have low VQ abnormalities that respond to increased oxygen. Shunt you can diagnose by increasing FiO2, and 100% oxygen ventilation perfusion abnormalities become irrelevant. If there's a persistent hypoxemia on 100%, that implies shunt. And low mixed venous is probably the case, at least in, when there's cardiac dysfunction and other things that lead to mixed venous oxygen tensions that are quite low. So just one sort of intricate physiology thing. I found this on Google Images, but it made the point. Here's normal up here. You can see blood flowing into the pulmonary artery that's blue, meaning deoxygenated. It goes into normal alveolus here, normal alveolus here. It comes out red. And so the lungs are doing their job. You get reoxygenated blood. If there's low VQ here, there's low ventilation, the blood kind of stays blue and it mixes with the red blood and you end up with hypoxemia as a result. If you have very low VQ or shunt, here there's cutoff of ventilation. There's still blood flow there, so there's perfusion without ventilation. Again, you get worsening hypoxemia. And this doesn't respond to 100% oxygen. If you put 100% oxygen here, the ventilation is blocked, and so giving 100% oxygen, you'll still have hypoxemia, and that's what defines shunt, at least physiologically. With high VQ, you can get areas where there's ventilation without perfusion, and that can lead to hypoxemia, but it's usually more an issue with hypercapnia. Just a couple teaching points there. Low venous oxygen can lead to arterial hypoxemia when there's shunt. So if you have blue blood coming in here, and there's areas that are perfused poorly, then you can end up on the arterial side with lower oxygen tension over here. Particularly when there's shunt, like here, if this blood has lower oxygen tension coming into the lung and there's perfusion without ventilation, you end up with hypoxemia over here. The other point that's critically important, which it took me a long time to understand, is overventilating one lung unit doesn't make up for underventilating another lung unit. And that's due to the shape of the oxyhemoglobin curve. You can't rob from Peter to pay Paul. So you can't overventilate one lung unit, get extra oxygen there, and then underventilate another unit and get less oxygen over there and expect to come out even. The reason is that overventilating one lung unit doesn't really add much in the way of oxygen because of the shape of the oxyhemoglobin curve. If the tension is already maximal there, you won't get more oxygen by overventilating. And so when you have ventilation perfusion mismatches because of the oxyhemoglobin saturation curve, you'll end up with hypoxemia. So what do we know is going on in COVID? The short answer is I'm not sure. If you look at Luciano Gattinoni's paper that was in the Blue Journal a few months ago, he looked at compliance here on the x-axis and shunt fraction on the x-axis here. On the y-axis here is number of patients, and he was saying that the compliance is relatively normal. I'll point out, though, that a normal lung compliance is about 100 mils per centimeter of water. I'm sorry, a normal respiratory system compliance is about 100 mils per centimeter of water. Normal lung compliance is about 200 mils per centimeter of water. The compliances we're seeing here are actually low compared to what you consider a normal person. Shunt fraction is also kind of variable, but certainly higher than what you consider normal. So you're seeing shunt, you're seeing low compliance, as you would do in typical ARDS. The point of this paper was to say it wasn't typical ARDS, but in fact, if you look at these numbers, they do look like sort of mild or early ARDS. I'll also point out the numbers here are different. It's 14 and 8, and so it's very hard to interpret this paper if you look at it carefully. The ends are different. The values aren't that different from other studies of early ARDS. If you look at the lung safe study, for example, the data look kind of similar. There's a fair amount of shunt here, and that may be amenable to PEEP or to recruitment, as you can see from the shunt over here. So take-home message so far. Even studies that claim this is not ARDS show physiology, at least in my view, suggestive of ARDS, including shunt. There's also this article that came out of Mass General. My former colleagues there, Corey Harden, Catherine Hibbert, and others, published on this. And this is their experience with COVID physiology at Mass General and Beth Israel Deaconess Medical Center. You can see PF ratios of about 182. You can see dead space of 45. And other parameters there that suggest this is typical ARDS. One thing that's a bit of a confounder is, at least early in COVID, we were doing early intubation. If you intubate somebody who's not very sick, you'll see numbers that look relatively normal. You'll see high compliance. You'll see gas exchange that doesn't look that bad, and that's a function of early intubation practice. But that doesn't mean the physiology is any different. It's just a marker of early intubation. They may look less sick as a result of that. So what can we do about hypoxemia in COVID ARDS? Well, again, I'm not sure. You can give adequate PEEP, and jacking up the PEEP can be helpful, but keep an eye on the cardiac output because you can embarrass cardiac output with excessive PEEP. Keep an eye on the mixed venous or central venous oxygen tension because if you do embarrass cardiac output, that number can go down. Keep an eye on dead space. I've seen several of these patients where you go up in the PEEP and the CO2 shoots up because of ventilation without perfusion. You can consider doing these recruitment maneuvers, so-called sustained high-pressure inflation maneuvers, currently unproven, but sometimes we'll do those. Dr. Bellinghausen talked very nicely about prone positioning. I agree with her conclusions there. It can be quite helpful, particularly if you're using open lung protective ventilation. We've been doing a lot of extracorporeal membrane oxygenation. That also has a role. My experience with nitric oxide and prostacyclin, at least in COVID, hasn't been great. Ongoing studies are being done out of Mass General and other places, so stay tuned on that one. Or you could tolerate the hypoxemia, but I would argue against that. Couple papers in New England Journal, including the one shown here, give you some cautionary note against tolerating low PO2. There was a lot more visceral ischemia, for example, if you read this paper carefully and stop prematurely for toxicity, so be careful about that. Don't tolerate low PO2. There's a couple other points before I conclude. One is that Martin Tobin had a very nice article in the Blue Journal just recently emphasizing traditional physiology, saying this isn't really that different. Hypoxia, for example, is not a big stimulus for dyspnea, and so silent hypoxemia is not that surprising. Blunted ventilatory drive may yield severe hypoxemia, so one of the mechanisms that we're seeing with these very low PO2s may be just that they're not ventilating as much as we might expect. There's also some controversy about ventilatory drive from hypoxia. So in this paper that's in press at the Blue Journal, high respiratory drive and excessive respiratory efforts predict relapse or respiratory failure in critically ill patients. They measured something called P.1, which is a measure of respiratory drive, and that was a predictor of relapse when weaning from mechanical ventilation. But there's some unpublished work that I'm involved in. Scotty Sands at Brigham Women's Hospital and Ludo have done some breath-holding studies from data from Italy, and there the suggestion is that high ventilatory drive may be protective, at least by these breath-hold measurements. And so the data right now are somewhat conflicting, although not exactly contradictory, but perhaps complementary. So stay tuned on that one as well. I'm not sure what is the mechanism exactly, and whether high drive is good, bad, or perhaps a mixed blessing. So I'll conclude by saying hypoxemia is characteristic of COVID ARDS, likely from ventilation perfusion abnormalities and shunt primarily. It is important clinically, though, because it's prognostic and because if there is a lot of shunt, that is perfusion without ventilation, that may be amenable to recruitment. Profound hypoxemia can sometimes surprise patients as well as doctors. The so-called silent hypoxia is getting a lot of lay press. There's an article in Science as well in the prestigious journal talking about that. So it's an important area. Whether high ventilatory drive is good, bad, or indifferent isn't entirely clear. I have mixed feelings about that, and I think the jury is still out. And then hypoxemia needs to be treated primarily with PEEP and with prone positioning. Other things I would consider less proven. So let me pause there. I'd be happy to take any questions. Thank you all for your attention. Thank you for the organizers for inviting me.
Thank you so much, Atul. That was amazing. You hit some really good high notes. And I did tell people to put their questions in the chat box. It did occur to me that we got a question very early on about what the role is of patient-induced lung injury, so self-induced lung injury, so people who aren't intubated, who are working really hard, because I know there is this debate about whether patients should be helped earlier versus allowing them to take these massive breaths.
Yeah, so the issues about self-inflicted lung injury, and I thought I had a slide on that, but I'll just speak otherwise. The theory that was proposed, I think Gatnoni was the one that was pushing it, was that initially there's a vasoplegic lesion whereby patients have poor gas exchange. They become hypoxemic and start having high ventilatory drive. High drive can create big transpulmonary pressures, that is stress on the lung. And if you have stress on the lung in the context of heterogeneous parenchyma, that you could create lung injury and ARDS. There's a paper by Colabo where they injected salicylates into the cisterna magna of animals and they could induce lung injury, and so that was the basis for it. I don't think that's a major player mechanism. The reason is twofold. Number one is high drive, at least in our data here that's unpublished, may be protective, and so I don't think people are damaging their own lung, even though I was a proponent of that theory before. I think that's not at least what we're seeing currently. The other point is that we're not seeing high drive. That is, these patients with silent hypoxemia, if we're measuring transpulmonary pressures or if they're generating huge stress on their lung through their diaphragm, we'd be seeing that clinically, and I don't think we've been seeing that. So I'm a bit pessimistic right now about self-inflicted lung injuries being a major player. Gatnoni cited a paper out of Switzerland, which isn't yet published, where they're intubating early, sedating and paralyzing patients early, and they had 100% survival. But until the details of that are published, it's unclear what to make of it. If you intubate somebody with a runny nose, they're not going to die, but perhaps they didn't need intubation in the first place. So right now, I'm not a big proponent of self-inflicted lung injury. Also, that L and H, those phenotypes about low and high elastance, we're just seeing variable compliance, as others have pointed out in the chat box.
Yep, exactly. So very clear answers there. And Varsha was asking, is there any evidence that early intubation with preserved lung compliance have shorter length of stays or less cytokine released or have a less complicated course? And sounds like you're saying that no, we don't know that yet.
Yeah, and my bias at least is that whether people have high compliance or low compliance has to do with what stage of disease they're in. I see many patients that come in with relatively high compliance, particularly if you intubate them early because you're trying to prevent dissemination of virus. And then the compliance goes down over time as the lung gets sicker and gas exchange deteriorates. And so we've seen that quite commonly where people start out with high-ish compliance, not normal, but high-ish compliance, and then it goes down over time.
And unfortunately, then we have to take into all these other complications that happen when you intubate somebody. And so other drivers, other lung compliance going down, like the ventilator-associated pneumonias and whatnot. We have gotten a couple questions. They want you to define ventilatory drive.
So, it's actually, believe it or not, a hard thing to define. So ventilatory drive is what your brain and your carotid bodies tell you to do in the face of a stimulus. So it can be drive related to hypoxia, drive related to hypercapnia. But it's basically, if I give you a stimulus, do you breathe a little bit or do you breathe a lot? And if somebody has high drive, that means they're jacked up and they want to breathe a lot. The P.1 is one measure of ventilatory drive that's shown on this slide. This paper is in press at the Blue Journal, as I mentioned. What it measures is the amount of pressure you generate during the first 100 milliseconds of a spontaneous inspiration. So somebody's breathing, you occlude their airway, you measure the pressure they generate in the first 100 milliseconds, and that's a relatively clean metric of respiratory drive. Can it be influenced by respiratory muscle strength and other factors? Absolutely, but in general, it's considered a reasonably clean metric of drive. And that drive to breathe is important because if you have very high drive, at least in theory, that could damage your lung, although I don't think that's a prevailing mechanism in COVID. If you have very low drive, that's actually been associated with poor outcomes in asthma. So Kikuchi had a paper in New England Journal in the early 1990s where people with low drive don't know when they're sick and they get near fatal asthma, don't realize how sick they are until it's too late. So your ventilatory drive, or how much you breathe in the face of a stimulus, is a very important factor physiologically. It's what we study in control of breathing.
Awesome. One of your favorite questions, I think, came up is, can you comment on the use of APRV or BIV ventilation in these patients?
Okay, so
ARDS, I would say.
So I'll start out by saying I don't have a ton of experience with it, in part because I'm biased against it. And I'll answer the APRV thing in three different ways. APRV stands for airway pressure release ventilation, where you have a high pressure, then you drop the pressure to a lower value and ventilate people that way. And I have some friends who I respect who swear by it. In fact, the late Brian Kavanaugh is one of my closest friends, and he had a paper on APRV, although I'll tell you he wasn't sold on it either. So I'll answer the question in three ways. Number one is John Marini, my friend and colleague at University of Minnesota, was asked to give a lecture on the evidence for APRV. And he showed up with one blank slide saying, there's the evidence for APRV. So basically, he was quite dismissive. That's the first thing. Second thing is there was a presentation at the critical care meetings a few years ago where somebody measured esophageal pressure during APRV. And one of the purported benefits of it is that you can minimize sedation and people can breathe spontaneously when the airway pressures are high, and that's true. But what he was measuring is very negative pleural pressures or esophageal pressures during high airway pressures. So that pressure difference across the lung, that is the airway pressure minus the pleural pressure, was extremely positive. And that's the pressure difference that stretches or damages the lung, the so-called transpulmonary pressure. And so what this person concluded was that APRV is a way of giving very high transpulmonary pressures without realizing it, because you're sedating or you're minimizing sedation, you're allowing spontaneous breathing in somebody with a high airway pressure, and you get that issue with stretch on the lung. And then the third argument is when you start out with a high pressure and then you drop the pressure, some lung units will collapse. Depending how far you drop the pressure, more units will collapse the lower you drop it. So think about which are the units that collapse. Well, it's the ones with the fast time constants. That's with the resistance and compliance that's very low. And so very low compliance is the stiffest part of the lung, and that's what is the fastest. So you start out with a high airway pressure, and you drop the pressure to some low value. The fastest time constant lung units, that is the stiffest ones, will collapse first. And at least in my view, that's the worst thing you can do if you're trying to do open lung protective ventilation, is collapse the most stiff lung units from time to time. So Art Slutsky's coined this term atelect trauma, where there's lung injury from opening and closing the lung. In my view, at least, dropping the airway pressure intermittently allows collapse of the fast lung units, and that, in my view, would promote atelect trauma. So I'm not a fan of APRV, although I'm happy to be proven wrong if somebody shows up with randomized trials showing I'm wrong.
And because we are talking about modes, I'm just going to carry on that vein. Somebody's asking, is there good data to, say that we should use ventilator, the volume control versus pressure control, or do you have preferences there?
Yeah, I think volume versus pressure, you can, it's a style thing more than anything. If you want evidence-based medicine, you go to 6 cc's per kilo versus 12 cc's per kilo, and you say 6 cc's per kilo had 30% mortality, 12 cc's per kilo had 40% mortality, and the ARDS published that in the New England Journal back in 2000. So you could say volume on that basis. But if you use pressure and aim for the same kind of volume targets, I don't have a major issue with that. I think you can achieve the same thing. People end up bickering about things that are relatively unimportant, at least in my view. As long as you're not damaging the lung, that's my main concern.
Great. I think that's perfect. And I passed a question from a few minutes ago. I want to circle back to that one. So Benjamin Wang was asking, could microaspiration of upper airway secretions be the cause of VQ mismatch and shunting? What has been your experience with subglottic suctioning? So I think he's talking about the endotracheal tubes that have that sort of suction port above the cuff.
Yeah, so could microaspiration be important? The answer is always yes. We're not seeing a ton of aspiration in these patients. We are seeing in some of our ECMO patients some ventilator-associated pneumonia, which we're now investigating. I don't have a ton of experience with the endotracheal tubes with suction or the subglottic suction. There was a randomized trial in the Annals of Internal Medicine a couple decades ago now that suggested benefit, but most of the benefit is early rather than late. And what happens is you prevent sort of Staph aureus, but Pseudomonas and some of the other nosocomial infections you don't prevent. And that seems to be related to the technology, that it clogs up over time, and so the late infections aren't prevented. It's also an issue about how to operationalize it. So do you, all the endotracheal tubes you put in have subglottic suction with them, or do you just selectively replace it in the prolonged intubations? They're not cheap either, and so in my view, they remain unproven. I think most of the guidelines, and I know Deb Cook spoke about this, saying it's not worth it. Again, I'm happy to be proven wrong. We don't typically use them, and ideally, we identify the right patients ahead of time, put them in patients selectively, and do it that way. But I don't know how important microaspiration is in COVID. I'm not sure.
Yeah, and I think you nailed it. It's sort of like if we could stop all aspiration, we would, because we know that those bacteria going down in the lungs and other things like the gastric acids and whatnot will drive inflammation, drive lung injury. So it's nice that people have come up with different ways to try and target it, but haven't panned out with beautiful data yet.
And also, I've
And
seen some. I'm aware of some. Sorry to interrupt, but I'm aware of some disasters where people have a regular endotracheal tube in, and then they try and do a tube exchange to put in a subglottic suction thing, and that's not easy in somebody with bad ARDS that's got prolonged intubations. I'm aware of people who've had complications trying to do that. The alternative is put it in everybody you're intubating, and then there's an expense and an unnecessary kind of thing. As I say, they tend to clog up over time. So at least last time I looked, the early infections were prevented much more effectively than late infections.
Awesome. I do want to give a shout out to the other experts on the line who have been busy answering some questions in the chat box. And we still have 127 people on the line. So if any of you have not gone to the survey, please do so now. I want to thank Dr. Malhotra for joining us and giving us such a wonderful, detailed explanation of, hypoxemia, what is known, what is unknown, and what answers might be coming down the pike, so to speak. And again, thank you to Dr. Lin, Dr. McGuire, and Dr. Bellinghausen Stewart for giving those awesome presentations, and to our ATS staff for hosting this session with us. Want everybody to take care, and we will be back here next Tuesday at 5 o'clock Pacific Standard Time, 8 p.m. Eastern Standard Time, and we look forward to seeing you then. Good night, everybody.
Thanks, Laura.